Most do well. So this is from a very robust database of transplant recipients in New Zealand, but the slide looked good, and the data is completely transposable over the data from the US. So the causes of death in a transplant population are, each organ is a little bit different, but by and large is not related to organ failure. So organs do fail and can cause, that tragedy, but most patients who succumb after an organ transplant succumb with a functioning graft, as you know. And the two leading causes of death after a transplant are cardiovascular problems, and we'll see that decrease year after year because, as you know, most of those complications are related to side effects of immunosuppression, and the immunosuppressant options are so much better than they used to be. And then cancer. So it's an important topic to talk about. How do we avoid that problem? If we look at kidney transplant patients, so recipients of either deceased donor or live donor kidneys, if you go decades out after a transplant, the incidence of cancer, now this does include skin cancer, which is typically quite curable, so don't get too depressed looking at this. It's to heighten your focus on the topic, not to be discouraging, is higher than 50% in many populations. If we look at the particular types of cancers that we'll address, so the most common are the ones on the bottom of the slide. So skin cancers happen 20 times more common in all solid organ transplant recipients than in the general population. And we'll see in some groups like heart transplant recipients, it's even higher than that. PTLD is an abbreviation for post-transplant lymphoproliferative disorder, in layman's terms, lymphoma. So there's a spectrum of PTLD, but it's we'll get into it a little bit because it's the one of the most common cancers after transplant and is 20 times more common than in the general population. And there's a spectrum of disease there. PTLD is related to, there are a couple of risk factors that we'll talk about, but there's a spectrum as benign as mononucleosis to benign lymph tissue growth, and then in the most severe form, lymphoma. Kaposi sarcoma is, you might think of it along the lines of skin cancer. It's a little bit different. So those are the most severe, those are the most severe and the most common, not skin cancer being severe, but the lymphoma and is the most severe and very common. Now kidney cancer really is an issue for kidney recipients. Okay, it's not a huge problem in the kidney recipient population, but the kidneys that are left behind, because we don't take out, typically we don't remove the recipient's native kidneys when we do a kidney transplant. Those kidneys are at higher risk for developing kidney cancer.
Now, and a question, Dave, if I may.
Please, yeah.
Why would you leave them in there if they are subject to the higher risk? The old kidneys I'm talking about.
That's a great question. The risk is, although the risk of kidney cancer is 15 times as high in a kidney population than in the general public, it's still a very low risk. So of 100 patients, very few will develop kidney cancer. And with proper screening, it can be treated with a very high rate of success if the cancer occurs. Kidney cancer is typically slow growing, and so we'll get into screening and all. Putting a dialysis patient through a bilateral nephrectomy, removing both kidneys, is quite a bit of surgery. And the risks of that are higher than the risks of leaving them in and then watching recipients to make sure that they're not the minority that will develop a kidney cancer, and if they are, take out the kidney then. Maybe you would have to take out not necessarily both kidneys, but maybe just one kidney. So there's some patients that have their kidneys removed before transplant, but it's not really because of this risk of cancer, it's because of some other